So what happens if you are someone in America who is dependent on Medicare or Medicaid and you can't afford, like I was talking to you and you mentioned that maybe I shouldn't be getting the gel shot anymore in my knee, but try PRP, which is your own stem cells. Nobody covers that. My insurance company doesn't cover that. Medicare doesn't cover that. AARP doesn't cover that. So am I to think that maximum health care with a 360-degree view is only for people, sadly, who can afford it? Is that what I'm thinking here? And it's true?
Totally.
Hi, everyone. This is Diane Gilman, formerly the Queen of Jeans on QVC HSN, but now the proud host of my own podcast named after my second book title, Too Young to Be Old. And who better to have on a podcast with that title than Dr. Doug Lucas, actually known as Dr. Doug on his own YouTube channel. This is a guy, if you are female and you are thinking about, oh my God, here comes menopause, or oh my God, I'm in menopause, or oh my God, menopause is endless. This is a guy you really want to hear. And he's going to provide incredible information about what I am always so passionate about, a 360-degree plan for health going into our 50s, our 60s, our 70s, and beyond. This is called Health Span Nation. He's got his own YouTube channel, and we're just going to welcome Dr. Doug. Hi, how are you?
Hi, Diane. I'm doing really well this morning. Thank you. I hope you are. It's great to be here.
Well, we were talking before the show about significant arthritis. I have it in one knee, my right knee. And Dr. Doug, I got to tell you this story. So, because I'm always complaining about healthcare in America. So, first of all, Mount Sinai wouldn't even treat me with a gel shot until we went through a whole drama with Medicare and it went on forever and finally get it. And okay. So, I'm an old girl. I'm almost 80 years old. So I think about the days when they used to actually make house calls, but actually doctors spoke to you. They knew you. They knew a little bit about what you were going through. And they were interested to know was what their regime was for you working or not. So here's yesterday. I wait and I wait and I wait and I wait. And the waiting room at Mount Sinai Hospital, orthopedics, is just jammed. Okay, finally get into a room, and then I wait and I wait and I wait and I wait some more. Then a strange woman comes in, not the guy I know who's going to give me lidocaine and make the pain tolerable. And I said, oh, where's that guy? And she said, oh, he went to get pizza. And I'm like, what? And she said, well, if you don't want me and you want him, I'm going to go tell the doctor and you can just wait. And I said, no, I don't want to wait like another hour and a half. Total attitude, walks out. Then two more strangers walk in. One of them this is her first day there. Doing what? I don't know. No one ever told me. And the other one is someone who's supposed to help the doctor spray lidocaine on, but does not do a very good job. The doctor opens the door and says, is the gel shot prepared? Yes. She walks in, doesn't even say, hi, Diane, picks up the needle, sprays on some lidocaine, not enough, jabs the needle in, then puts some other thing in the needle. She's done in about 20 seconds. And she says, gotta run. That was it. That was it. Not, how's your knee, Diane? How are you doing with physical therapist? You think you need surgery? Let's discuss it. What? Nothing. Nothing. Which is, I think, doctor, totally antithetical to what you propose as health care for midlife women and beyond. Please take the stage. I leave it to you, the expert.
Yeah, well, I appreciate that story, and unfortunately, that is the standard of care in America and across the world as well, from what I hear. But my experience is in the U.S. And as an orthopedic surgeon, that was my original training. So my clinic was just like what you experienced. I finished my training at Stanford. Even at prestigious institution
Yeah.
like that, you have patients that are waiting 2 to 3
Yep.
hours, and you have very high level people there. But we have, I was seeing 60 to 70 people a day. So while it's really easy to look at doctors and say, oh my gosh, I can't believe you would treat me like that, from the doctor perspective, it's really hard to maintain that goal of talking with your patient, getting some background. It's just impossible, unfortunately, in the traditional medical model. So I left the traditional medical model after practicing for about 7 years. I was in both the academic setting, I was in a hospital employed setting, and then I was finally in a private practice setting. None of them could satisfy my need to do exactly what you said, which is I want to actually talk to my patients. I want to hear what's going on with your knee. What have you really tried? What are the other things we can do? What are you doing from a lifestyle perspective? What are you doing from an exercise perspective? What supplements are you taking? Right? Getting to the root of all of these things, understanding what are the other things we can do other than simply what is an intervention I can provide. And as an orthopedic surgeon, unfortunately, it's going to be injection, it's going to be surgery. Those are what we do.
Yeah.
And so I don't fault doctors for that in the system, because I was exactly the same way. Hey, how you doing? Here's your shot. Oh, sorry, I forgot the lidocaine. Bye. I'm just thinking, how can I make up seconds so that I can actually get out of here on time today? Because I haven't all week. And that's
Wow.
just sadly what it takes. I mean, most doctors, especially if you're seeing like I was high volume, 60, 70, I worked with a guy that saw
Yes.
100 patients a day.
Yeah.
When you're
That was
seeing
her.
that many patients, there's nothing you can think about other than how do I get the documentation done? How do I keep up with the patients? How do I get them roomed appropriately, x-ray appropriately? How do I move all this stuff around? Because it is like a chessboard that you couldn't imagine on the clinical side. So I don't know what the solution is from the traditional medical model. I don't know how we manage the people that we have in our country and across the world with the type of care that people expect and the type of care we want to provide. I don't have a solution for that. But what I did come up with a solution for is I can, as a provider, exit the traditional medical model. I can start my own practice and I can treat patients the way that I want to treat patients. And the way that we do that is by getting rid of the traditional model. We use a membership style model. Patients come in. The expectation is I'm going to sit down with you for an hour. We're going to talk about lifestyle. We're going to talk about all of your lab results. We're going to talk about a plan that includes lifestyle, supplementation. We're going to talk about hormone optimization, replacement. We're going to spend a lot of time going over these things. And then you have everyday access to me and my team. You can send us a question. We will get right back to you. And a lot of practices do that. But the amount of back and forth and the time between the back and forth leaves a lot to be desired because they have too much volume.
So, do you call that the concierge
It's
plan?
it
Because
kind of. So there's a
that's kind of what
concierge piece to that.
yeah,
Yeah,
you don't even, now in New York City, you barely get medical care. If something goes wrong with you and you don't want to do, and my GP raised the price to $5,000 a year.
yeah,
And I'm somebody who sort of is not really invested in going to the doctor every other minute. And so I may only see her twice a year.
sure.
And that just seems exorbitant. But if I don't do that, I'm backed into a corner
You don't have
where I have
access.
to go for those
Right.
emergency care centers.
Yeah.
And everybody now complains they don't diagnose correctly. They don't like the teamwork.
Right.
So what I envisage for myself as a female who's lucky enough to be aging, I envisage 360-degree care. I want to know about traditional methods. I want to know about activating a plan that's going to improve every day of my life right now. And I want to know about not hypothetical, but kind of cutting edge, advanced therapeutics. And I also want to know about supplements,
Yeah.
which I do believe can really reinforce your health. I love what you talk about when you call it health span
Right.
rather than lifespan. Because you know what? I always thought that corny phrase, "Oh, you've got nothing if you don't have your health." Okay, I got breast cancer. I got behind that. I
Yeah.
had always thought, "Oh yeah, okay, someone's saying this to me again," but it's actually true.
Right.
So, talk to me about how you put all those components together. Because, for instance, I'd love a plan where something beyond the gel was happening for my arthritic knee.
Yeah.
And beyond that, somebody said to me, "Oh, you should go to a hyperbaric chamber once a week. You should go for red light therapy. You should. I
Sure.
believe that there are systems way beyond. Well, I mean, nothing is offered in the hospital except get the shot in
Right.
your knee.
Right.
There must be more to it than that, and better ways to handle pain in a weight bearing joint. So
Sure.
please, doctor, give
Yeah.
me a clue here."
So let's say, for example, if you were a patient in our clinic and your primary goal, because this is one of the first things we do, is we say, well, what are your goals? Right. So your goal, I would imagine one of them would be, I need to be able to do more with my knee. And it's not so much fix my knee pain. We know that, yes, you have knee pain, but really your knee pain is limiting you. It's preventing you from doing the things that you want to
Oh,
do.
totally.
So your goal would be, I want to be able to do X, Y, and Z with my knee. Okay.
Yep.
So let's just use that as a primary goal. As we go through the list of things, we'll talk about lifestyle. So you would be meeting with our coaching team, our dietitian team. They have fantastic backgrounds in kind of what I would consider not typical registered dietitian terminology and access. And so they're going to think outside the box from what most nutritionists are thinking, and they're going to help you to use whatever tools necessary to achieve your goal. So from a
Yeah.
dietary perspective, that's covered. Right. And then we're going to talk about other lifestyle things. So we have an exercise physiologist, PhD on staff, who can help to kind of guide you from an exercise perspective. These are the things you could consider. Now, what we have from there are some options that we have. A lot of times people want to use somebody in person, which is fine. Those are the two primary ones. But then we also talk about sleep. We talk about, what does your social circle look like? We talk about other stress mitigation factors. What are the lifestyle things that can help you to achieve your goals? And when it comes down to like something like knee pain, for example, how you sleep makes a difference. Your stress level makes a difference. What kind of exercise you're doing makes a difference. What kind of diet you're eating makes a difference. So you have to cover all those things. And that's where traditional doctors just don't have the time. Even if they have the training, they don't have the time. And then the next level is supplementation. Now, this is where the doctor starts to get involved, or the PA or nurse practitioner. So the providers are getting more involved in the supplement side. Not that our coaches don't know them too, but we use the biomarkers. We use our blood test to help us guide what things are you likely deficient in. Because you could take 1,000 supplements a day if you listen to the internet. So which ones are you actually going to see the most benefit from? And using either a blood test or a functional test to help guide that. So now we have a supplement plan in place that's really, we're using biomarkers to help us guide the use of that supplement. Then we know when we can discontinue it. Is this going to be forever? What's the plan with this thing? And then from there, we're going to really kind of focus on those things moving forward, but we're going to have a conversation around hormones. We're going to have a conversation around what medications are you on? Are you on too many? Are you on conflicting meds, right? Like, it is such a challenge as a consumer of healthcare, not being a provider, a doctor, to look at these things and understand, what are the different tools that you have. We also talk about things called peptides, if you're familiar with those. And then we have the option to consider pharmaceuticals as something to prescribe. We don't do it often because our approach really is pretty much drug-less, unless somebody really has a need for one. Then,
so I
go
don't
ahead.
take any drugs at all except to Aleve every morning. I do take supplements, but I would love it if I had a team and somebody said, "You know what? I'm going to map out a gluten-free diet for
Yeah.
you, because gluten is, or I'm going to map out an anti-inflammatory diet for you, because that's going to really aid you. And I wish I had somebody who said, okay, we're going to give you a series of exercises you can do on your own, even on top of a physical therapist,
Right.
that's going to aid your knee. It is amazing to me that I live in the wealthiest city in the world, New York City.
Yeah.
Every one in every 24 residents is a millionaire. And I don't even get 15 minutes of the doctor's time for a consultation.
Sure.
Not even. And she sees me walking in with a cane, which that would be my number one goal to get rid of,
Yeah, sure.
and doesn't even say to me, oh my God, Diane, you're on a cane. We should talk about, no, nothing.
Yeah.
Just, you know, I used to think I was lucky if I got 20 minutes of a doctor's time. Now I think I'm lucky if I get 2 minutes. So
Yeah.
I want to ask a question. And this is probably somebody who has a general aversion to doctors, me, had to go through breast cancer, and am very grateful to the team at Mount Sinai for really saving my life, seriously.
Yeah.
When you were going through chemotherapy, you had a dietitian on call 24/7. But it turns out it wasn't for optimal health during treatment. It
Right.
was actually because a lot of foods garner bacteria, and they were very afraid you'd get an infection you couldn't deal with.
Yeah.
But they have carved into their wall in the Grand Hall of Mount Sinai. It's like the 10 Commandments. It's the 10 points of taking care of yourself. And I really respected it. Don't smoke cigarettes. Don't drink hard alcohol. Don't eat red meat. But nothing. No follow through beyond that. And it's probably true for every medical system. So what happens if you are someone in America who is dependent on Medicare or Medicaid, and you can't afford, like I was talking to you and you mentioned that maybe I shouldn't be getting the gel shot anymore in my knee, but try PRP, which is your own stem cells. Nobody covers that. My insurance company doesn't
No.
cover that. Medicare doesn't cover that. AARP doesn't cover that. So am I to think that maximum health care with a 360-degree view is only for people, sadly, who can afford it? Is that what I'm thinking here? And it's true?
Totally. And there's
Wow.
unfortunately, when you look at and I'll start from the provider perspective. So when I was in practice and I was fighting the good fight and trying to take care of my patients the way that I wanted to, I would spend time talking about lifestyle. And obviously I always got behind and then my patients were waiting. But I thought it was important. When you look at it from the business of medicine, and you look at what doctors get reimbursed for a visit, especially when you start getting into state-run policies like Medicaid policies. Literally, there are some policies that pay so little for a doctor to see a patient, it actually costs them money.
Yeah.
Right. So not only is it not profitable, it actually costs them money. So how could we ever expect somebody to run a business at a loss and take good care of patients? It's impossible. The type of information that you want, the access that you want to have is, I think, what we should have. But how do we do that at scale? How do we have, because in order to provide the answers to the questions, you're basically talking about my team, right? So we have an exercise physiologist, we have out-of-the-box RDs, people that have master's degrees, that have decades of education. We have coaches that are experts in lifestyle and in exercise and in mindfulness and stress mitigation. And then you have myself, and you have my PAs and nurse practitioners who, again, all well trained outside of the traditional medical model. First of all, there aren't that many of us. And secondly, to have access to us is going to be expensive because
Yes,
we,
and you are virtual. Is that
true,
correct?
yeah, right. We can work with
So
anybody in the
there's
US.
a lot of people, especially older people. For me, there's no barrier there. I like it.
Clearly.
Obviously, my whole life is virtual. I'm on a podcast. I was on
Right.
TV. It's all done with a barrier in between through electronics, the miracle of. But I want to just zero in on one part of it that is really essential to this audience, and that is helping women
Yeah.
in midlife and beyond to unlock longevity, health span, performance, a good lifestyle. And one thing I heard, and it really stuck with me, is yes, there is perimenopause, but when you go into menopause, you are literally in menopause for the rest of your life. So, talk to me a little bit about what prompts you when you have a menopausal patient. How do you handle the rest of your life? And for me, I was told I had an estrogen based cancer that was also a stress based cancer. I was able to take care of the stress. I took that very seriously. And then I cut out all forms of estrogen,
Yeah.
including soy sauce, anything that was going to manufacture estrogen, I got rid of. And I think that had a lot to do with the deterioration of my knee and my overall skeletal
Absolutely.
health.
Yeah.
How would I deal with that? I mean, I would love to be back on hormone replacement again, but I'm scared.
Sure.
Everything is like, no, no. When it comes to estrogen, no, no, no.
Yeah.
So,
Well, let me break this down into two different groups. So let's talk about first women that don't have breast cancer or haven't had breast cancer, because that's most women, fortunately, right? However, it is very common. So you are among several million women that are breast cancer survivors. So we absolutely need to address that group as well. But let's start with people that don't have a personal history of breast cancer when it comes to HRT. Some studies that came out in the early 2000s exploded, and you probably remember all this. So the studies in the early 2000s, the WHI is the most well-known of them, the Women's Health Initiative. Those studies changed the landscape of hormone replacement probably indefinitely, right? Millions and millions of women were taken off of HRT because of the fear around breast cancer and estrogen.
yeah.
What's crazy about those studies is, because I've looked at this in depth, I talk on it on stage in front of audiences of physicians. When you look at the original publications in 2002 and 2004, they didn't show that estrogen caused breast cancer. They never did. And yet the takeaway was that estrogen causes breast cancer. But let me clarify that statement. So what they really showed is that if you were on a combined hormone replacement therapy with an oral estrogen called Premarin, which you probably remember well,
Of
and then
course.
a
Yeah.
synthetic progesterone called Provera, and put together, that's
Yes.
Prempro. And so when you're on Prempro, these oral HRT, there was a trend, not even a significantly different change, but a trend toward an increased risk of a diagnosis of breast cancer. If you follow that with the follow-up study for the women that were only on the Premarin, there was a trend toward protection of breast cancer with that estrogen therapy.
They switched me off of Premarin. They said it wasn't the good stuff.
It's not the good stuff, but it's
Yeah.
what was studied at the time. But so at the time, the takeaway should have been, man, these synthetic progesterones seem dangerous. But that wasn't the language. The language was hormone replacement therapy, i.e., estrogen causes breast cancer. And so, again, millions of women taken off, like unmeasurable amounts of suffering as a result of the misinterpretation of these data, right?
Oh, yeah.
So then fast forward, just last month, a publication was studied by the WHI group in, I think it was JAMA, but anyway, it was published in a major journal. 20-year follow-up of the WHI, because we're in 2024, right? So now we have 20-year follow-up of the 2004 study and 22-year follow-up of the original study. What happened over those 20 years is that the significance that was not statistically significant but trending became significant in both groups, meaning that the estrogen group became statistically significant and it continued to widen, meaning that there was a very significant protection from breast cancer with estrogen. Protection.
So where does that leave any of me and my
Yeah.
sisters who have been, and I say that as a female community, who have been through breast cancer? And, you know, I do want to say, after I was very, very lucky, however they formulated my chemotherapy or however my body dealt with it, the side effects were subtle.
Yeah.
They weren't hitting me and clobbering me over the head every day.
Yeah.
So I was very lucky in that sense. And then I was shocked. The aftercare was brutal. And we went through drug after drug. And I said, you know, finally I called up Mount Sinai.
Can't do
I
it.
was in
Yeah.
tears and said, I'm going to wind up in a wheelchair
You were on
in
some
a
kind
week
of
or so.
an estrogen blocking drug, right? Tamoxifen or
Totally,
AI.
total
Yeah.
estrogen blocking.
Yeah.
But unlike tamoxifen, which is for younger women, this was something for women who were already well into menopause, and the aches and the pains in my joints were like nothing I have ever experienced.
Mm-hmm.
And so after telling me that I've got to take this drug, about my chances of survival without it, which were not supposedly good, I couldn't take the drug. And I walk around with this fear and guilt that somehow I couldn't tolerate it.
Right.
But I couldn't. And they only had 3 choices. Here there are 185 kinds of breast cancer, but only 3 choices.
Yeah.
As aftercare. So what does somebody like me do? And what do we do? My body, I think, screams for estrogen, but I can't take it.
So let me just finish this statement around estrogen, because I got to be really careful what I say, because I'll be taken out of context. I could be crucified for this. So when I say that estrogen doesn't cause breast cancer in that study, I want to be clear that estrogen can fuel breast cancer, meaning that if you have an estrogen receptor positive breast cancer, like it sounds like you did, then if you have exposure to estrogen, it will likely make that cancer grow faster. This is the oncology theory, and it's true to some extent. So when women are on estrogen, then we have to be cautious of breast cancer, because it is the most common cancer diagnosis in older women, right? So there is a balance there. I would never say that just take estrogen, don't worry about breast cancer. That would be irresponsible. So for most women, it's an easy discussion. If they haven't had it, and depending on the family history risk or their genetic risk, then it's something that we can take and watch. And that's an easy conversation usually, although still so much fear around taking estrogen in breast cancer, even though it's protective of breast cancer. So then you talk about women that had breast cancer. So there is a growing body of literature that supports the idea that estrogen is likely safe, depending on the tumor, depending on the cancer, for women that have been successfully treated for their primary cancer. There's an author that you should read. His name's Avram Blooming, Dr. Blooming. He's an oncologist. He treated breast cancer primarily in his practice. He wrote a book called Estrogen Matters. If you haven't read it, you should read it.
I've heard of it.
Yeah, you should absolutely read it. There is an entire chapter in there on I'm trying to remember the numbers. I want to say it's 15 studies that have been done looking at taking estrogen after breast cancer for women that are breast cancer survivors, and only one of them showed an increased risk of recurrence. 1 out of 15. And when you look at that one study had a lot of flaws in the way that it was designed, mostly that they didn't screen for breast cancer in the first place, so we don't know, did they have breast cancer already? And so all of those studies essentially showed that there was no difference or there was no increase. And for some, it was actually protective. So there is a role for estrogen therapy after breast cancer. But this is a very unique conversation depending on the type of cancer, the grade of the cancer, the stage of the cancer. And so this is where you have to really talk with somebody who is A, open to it, which most doctors are not, but B, understands it. And so we can have a real discussion about the risk benefit.
Just because we're sort of coming to the end of this, and this is so fascinating to me, and I think to any woman who's saying to herself, I'm 50, I'm 45, I'm entering into perimenopause, I'm freaked out, my whole life is going to change. Can you just give a closing statement on health span and making the journey through menopause, which actually goes on forever for women, something to no longer fear, but be able to cope with and to actually thrive?
Yeah.
So I'm fascinated to know, because when I went through it, which was a good 30 years ago, there was nothing. It was sort of like, yeah, okay, well, this is the end of your female life. Yeah. Good luck and goodbye.
We didn't talk about it.
Hear.
Yeah. Yeah. So it's there's a great movement in the menopause space right now, which is awesome. Right. And I'm happy to be a part of it. And it was really thrust on me because of my patient population. We didn't really talk about this, but I mostly treat women with osteoporosis and women looking to optimize hormones. That's sort of our sweet spot group of patients that we're working with. And so the women's health menopause issue was sort of thrust into my practice. It wasn't something that I pursued, but you're right. 30 years ago, 20 years ago, I mean, even 10 years ago, there was very little discussion around women's health in general. Women have always been marginalized in the healthcare system.
Totally.
But the misogyny around what is reasonable to even discuss with a woman is unbelievable. And so when I started looking into the space, it blew me up. And I realized, man, this is something I really want to dig into, because my personality is pretty confrontational. I like to look at a problem, dissect it, and just tackle it. Like I'm kind of a ferocious researcher in that way. So this is a problem that I love. I just love it. And so for me, what I would say to your audience is, when I look at menopause and I think of it through the lens of health span, we have to get away from this idea that it's natural for women to age in menopause gracefully and that they're going to lose their hormones. And if you want to do that, that's fine. I don't want to say that's not fine. But think about it this way. You're going to go through menopause in your 40s to early 50s, most women. You have the potential in today's economy and medical world to live to 100, 120 years old.
Yeah.
You're going to live half of your life like this. So from my perspective, I would argue, let's get away from this idea that aging gracefully is the right thing to do. And if you're having symptoms, shut up, woman. We don't want to hear it.
I think that's what graceful means. Shut up.
Right. Stop complaining. Right. So let's look at the symptoms. Let's use the tools. Let's be smart about it. We don't need to be risky about it, but let's be smart about the tools that we have. And hormone replacement is one of those tools where there's more controversy than anywhere else. And the idea that you should be able to start it, you should not feel bad about asking about it. You should not feel bad about talking about things that are uncomfortable, like vaginal dryness and loss of libido. Like, these things are important for our relationships. And then be able to talk about this thing and continue these things for the next 40 to 50 years. Right? This is not a 10-year problem. This is a 50-year problem.
Yeah. And I'm going to end this too by saying that I feel, and it is the reason why I am in an area of health and actually even spiritual well-being, where we see as a society old age as useless, as a dead end, as punishment. It's almost a punishment. I always say, to me, it's a privilege, not a punishment. But when I say that, I'm going to tell you, you are going to age with aches and pains. And I wish there were more people around like you, Dr. Doug, who see it from a 360-degree point of view and can hit major points.
Yeah. Well,
and solutions.
There will be. There will be.
I'm hoping so. And the other thing that's weird, but I think for anybody brought up, let's say from 40 years backwards with electronic devices and always seeing something on a screen, virtual medicine is going to seem natural. I
There's
think for older patients, they feel somehow they're being cheated by not getting personal time. But no, I don't feel that way. If you ever
yeah.
want to use me as a test patient, I'm right here.
Yeah, we deal with that because we're tech heavy. We have obviously we're a telehealth platform, but all of our
Yeah,
platforms require somebody to be relatively tech savvy. But we have patients in their 80s that do just fine. And that's probably not
yeah.
all patients in their 80s, right? But I'll tell you, there's very little that we can't do either directly or indirectly through telehealth. So this idea that you need to go see your doctor is very antiquated. There is certainly a role for a
I
physical
think so
exam. I
too.
wish I could do a physical exam on everybody, but I can see so many more patients and impact so many more people if we do it this way.
Yeah, and I want to applaud you because I think the future is here and you're the future. And
Oh, thank you.
you are stepping forward into a way of dealing with aging and the human body and the things that happen to us, especially as females, like menopause, that are going to become hopefully a norm in medicine. But the other thing I love about it is with telemedicine, I think you can use your time more efficiently and the patient can get more activational treatment.
Yeah.
I want to thank you so much. This I could talk to you for like 12 hours. This was so fascinating, and bravo to you.
Thank you, Dan.
Seriously.
I really
Cheers.
appreciate the opportunity.